Yes, we can.
Okay. So today's topic is menopause, which is also a main phenomena of your case 8. So at the end of the lecture, you should be able to define the term menopause, right? Its age of onset, factors affecting it, obviously the pathophysiology, the main presenting complaints of menopause and their probable explanations, lab markers, consequences of menopause, and management, right? So these are the ILOs of today's lecture. Let us start with the definition of menopause. What is menopause? So it is a term used to announce stoppage of ovarian activity. Stoppage of ovarian activity. And it marks the end of childbearing period, means after the menopause a lady cannot be pregnant, right? So it is very simple: stoppage of ovarian activity and the end of her childbearing period. Age of onset, it is between 45 and 55 years. It is between 45 and 55 years, and on an average you can say 51 years, right? Also, it is important that there is no reliable lab test. You cannot diagnose that in this month or this year menopause will happen to the female. No, there is no reliable lab test, but it is genetically determined. Means a woman can expect to be um, have her menopause around the age of menopause of her mother, right? So it is genetically determined. Suppose the mother, she got the menopause at the age of 50, so it is very likely for her daughter to be to get the menopause at the same age. Okay. Why it is important to study menopause? It is very important because most of the ladies, they reach the age of menopause, and there are so many symptoms which out of which there are many which is painful, right? So it is important to know the onset of menopause, so that we can manage it on time, right? And its complications can be reduced, because menopause is associated with health problems such as osteoporosis and cardiovascular morbidity and mortality, right? Because estrogen is cardioprotective, and due to the menopause, levels of estrogen is very, very low, and it will lead to cardiovascular morbidity and mortality, right? So it is important to know about menopause. This menopause can occur naturally, or it can be induced, right? Naturally means it is physiological, right? Uh, Here, if she gets natural or spontaneous menopause, then the symptoms will be gradual, and it is good for her because symptoms, it will come gradually. But if it is induced, which is also called as secondary due to diseases of the ovaries, where surgeons, they need to remove the ovaries, like for instance, cancer of the ovaries. So the treatment is total oophorectomy, means removal of the ovaries, right? So in that case, symptoms will occur abrupt, means all of a sudden, right? So far we have learned about the definition of menopause, why it is important to know about the menopause, and its uh, types, natural and induced, or you can say the secondary, right? Causes of menopause. See, in this, there are slides where there are repetitions. Like, again, here they have explained the natural and the induced menopause. So, natural, as I said, it is physiological, right? It is a part of woman's normal aging process. Okay, it is absolutely normal if a woman she gets her menopause. And as I said earlier, also, it marks the end of woman's potential childbearing years, right? She cannot be pregnant after menopause. It occurs because the ovaries, they gradually slowing down their function, right? And the second category was induced, which is also called as iatrogenic. I hope you all know what is iatrogenic, right? This can be caused by surgical removal of both ovaries or disruption in normal ovarian function due to chemotherapy or radiotherapy, right? Suppose she developed ovarian tumor and she is on treatment, either chemotherapy or radiotherapy or combined. So ovaries cannot function normally, okay? So it is induced, secondary, it is not physiological, right? Uh, Let us start with natural menopause. We will study in more detail. As I said, it is a normal physiological process. So, menopause is preceded by a transitional period, right? It will be preceded by a transitional period which is associated with irregularities in ovarian cycle with infrequent ovulation. Ovulation, if you take the menstruation as of 28 days, so on 14th day, there is release of ovum under the influence of luteinizing hormone. Okay, so that is called as ovulation. So in perimenopausal phase, or you can say the transitional period, this ovulation is not regular. There is infrequent ovulation, means one cycle will be um, ovulatory cycle and the other will be anovulatory, like this. There will be irregularities in ovarian cycle. Okay. So ultimately, what will happen? There will be reduced fertility and less hormone production, estrogen and progesterone. It will be produced in very less amount. Okay. And this change is called as menopausal transition or climacteric period. Okay. And the symptoms which she will develop in this phase, right? So the here first I will show you this picture. It shows the phases of menopause, perimenopause, right? uh, then we have uh, menopause, and this is the postmenopausal period, right? So menopause, as I said, it will occur on an average at the age of 51 or between 45 and 55 years, right? So here there will be the last period, last menstrual period. And after that, in postmenopausal period, there will be no periods. Okay. And during the perimenopausal phase, this is the first phase of menopause, the periods will be irregular, irregular periods. Okay. So let us start with perimenopause. Uh, so here, the normal ovulatory cycle, uh, it will change to complete cessation of menstruation. Okay, there will be marked menstrual irregularities. We will discuss later in detail, more detail about these menstrual irregularities. Okay, and this phase, it may begin years prior to menopause. Suppose the lady, she got the menopause at the age of 50. So these symptoms, these changes may begin, I mean, 3 to 4 years before, right? Maybe at the age of 47, she will develop this transition phase. Okay. Now, what is the mechanism, pathophysiology of menopause? So, first is burning out of the ovaries. Burning out of the ovaries. You all are aware that at puberty, 300,000 to 400,000 primordial follicles are present in the ovaries, right? And throughout a woman's reproductive life, about 400 primordial follicles grow to mature follicles and they ovulate at the time of ovulation, right? And hundreds or thousands of ova they degenerate, right? This is the normal thing which occurs in females reproductive life, right? At the age of 45 years, only few primordial follicles are left to be stimulated by FSH and LH. You know, there's these hormones, follicle stimulating hormone and luteinizing hormone. They are required for the development of the follicles, right, which are released from the ovaries, and mm, uh, this luteinizing hormone, which is responsible for ovulation, right, and the production of estrogen by the ovaries is markedly reduced. This occurs at the age of 45 years, right? The second thing is whatever follicles are remain, for them aging occurs. Aging of the remaining follicles. So what is the aging? What changes takes place? These follicles cannot respond to the action of pituitary gonadotropins. Pituitary gonadotropins means FSH and LH, and they fail to ovulate, right? Thus, there is decline in ovarian estrogen and inhibin production. Inhibin is a hormone which is secreted from the granulosa cell, and this inhibin hormone, it inhibits the um, release of this FSH hormone, right? So when there is fall of these hormones, there is less negative feedback on the pituitary and hypothalamus. You know the feedback mechanism, estrogen and progesterone. Uh, if they are less, then in the anterior pituitary, FSH and LH, they will be more, right? So these hormones are less, so there will be less negative feedback to the anterior pituitary, right, and hypothalamus, and there will be significant, or you can say detectable, rise in FSH and LH hormones, right? The same is, I mean, there is repetition. We'll start from here. See, before we go for this diagrammatic representation, uh, let us discuss this one. See, the main important for MCQ also, the main type of estrogen present during the reproductive period is estradiol, that is E2, okay, before menopause. While the predominant estrogen in menopausal women is estrone, E1, okay. So before menopause, estradiol E2, and after menopause or in menopause, it is estrone E1, right? So what we have discussed so far, there is absence of ovarian follicles. Just now we have discussed in these two slides, okay, aging and the burning out of the ovaries. finally there is less follicles and degeneration of granulosa and theca cells. So because of these changes, what happens? There is decreased estradiol E2 production and reduced negative feedback. Okay. So because reduced negative feedback, so what will happen? This FSH and LH level will increase, right? And because of this, there will be increased androgen formation by the ovarian stromal cells. Instead of this estradiol E2, there will be more production of androgen, okay, by the ovarian stromal cells. And finally, these androgens, it will go to the periphery, mainly the adipose tissue, to be converted to form estrone or E1. Okay, so that is the reason in menopausal women there is estrone E1, and before menopause, the main estrogen is estradiol E2, right? Okay. Also, there is decrease in inhibin. As I told you that this inhibin, it is secreted from the granulosa cells and it inhibits the FSH. Normal function is. But here it is decreased. Okay. It is decreased. So there is early FSH rise. Okay. So it will cause what? It will shorten the follicular phase. We have follicular phase and the luteal phase, right? So this phase, it will be shortened. So there will be short cycles. Polymenorrhea. Polymenorrhea means short cycles. I mean, the lady will get her menses every, maybe 20 days, 25 days, sometimes maybe 18 days, right? So there will be short cycles, which is called as polymenorrhea. Polymenorrhea. Poly means many, okay? Many cycles. Accelerated, because of that, what will happen? The short cycles, so more follicles, it will be degenerated. Okay, so there will be infrequent ovulation. Accelerated follicular depletion, it will lead to decreased number of recruited follicles, and ultimately there will be infrequent ovulation also. Infrequent ovulation, so fertility will be decreased, obviously. Okay, and it will lead to long cycles. Earlier there was short cycles, okay, due to early rise of FSH, which is called as polymenorrhea. And then there will be long cycles. Cycles will be more than 35 days. The lady will get her menses um, in maybe in every 35 days, 40 days, 45 days, maybe 50 or 60 days, okay, which is called as oligomenorrhea. Oligomenorrhea. In this, there will be infrequent menstruation. Infrequent menstruation. Okay. The lady might get only 4 to 8 cycles in a year. Okay. So this is called as oligomenorrhea. Also, uh, there will be no corpus luteum. So there will be no progesterone. Okay. And the lady will bleed, there will be lighter bleeds, which is called as hypomenorrhea. Hypo means less. Hypomenorrhea means she will bleed for only 1 or 2 days, and the bleeding will be very scanty, very scanty. Okay, so these are the terms: oligomenorrhea, infrequent bleeding, right? Cycles will be more than 35 days. Hypomenorrhea, it is lighter bleeding, less bleeding. And polymenorrhea is cycles are shorter, okay, um frequent menstruation. this one, polymenorrhea, frequent menstruation. Okay. And oligomenorrhea is infrequent menstruation. Hypomenorrhea is less bleeding, less bleeding. Okay, so ultimately, what happened? The estradiol is markedly reduced. So this is the main culprit of uh, menopause. Most of the symptoms which menopausal female she suffers, it is due to reduced estradiol. Okay, so symptoms will, because of these changes which we have discussed, eventually the symptoms will start to appear. FSH will increase, and free testosterone, that will also increase. Okay, luteinizing hormone, it will also increase, which will stimulate the formation of androgens, and it will increase the androgen estrogen ratio. Also, there will be peripheral aromatization of these androgens. Okay, aromatization means it is a chemical reaction in which aromatic compounds are formed from non-aromatic precursors. Okay, and ultimately there will be increased level of estrone. This is estrone. Okay, which occurs in uh, menopausal female. As I have already told you in this slide, that the main type of estrogen present during the reproductive period is estradiol, right? And in menopausal women, it is estrone. So, because of all these changes, there is uh, increase in estrone level, right? This is E1. Now, symptoms of menopause, which is due to decreased estrogen levels.
Doctor,
Yes. Oh,
Doctor, I didn't understand why there was a switch from polymenorrhea to oligomenorrhea.
you didn't understand why we switched from.
Yes,
Okay. See, here it was due to the FSH, okay, which shorten the follicular phase. So when the follicular phase is shortened, then what will happen? The cycle will be shorter. Okay. So here this is polymenorrhea. Now ultimately what happened here, that the number of follicles, they are depleted, right? And there is infrequent ovulation. See these I mean what should I say? See, overall, I mean, there is decrease in the uh, follicles, number of follicles. Okay, less follicles are, I mean, available, and uh, they also, the changes which I told you here, that they don't, I mean, they don't respond to the this one, FSH and LH, right? So when they don't respond, then eventually the cycles will be longer, right?
yes,
Yeah, they will take time. So this is the reason here why there is a these cycles, they are I mean long, more than 35 days. Okay. So this is my explanation. If I'll get something else, inshallah ta'ala, I will share on the WhatsApp group. Okay. Uh, they usually appear before the cessation of menses, and they I mean the transition phase. Okay, transition phase. They vary markedly from one female to another. I mean, it is not fixed. As I said, the age is, I mean, it varies 45 to 55 years, right? So, this transition phase and the symptoms, it also varies from female to female. Some females, they get the symptoms very hard, and the other females may get less, right? And as I said, these symptoms are mainly due to the estrogen. Estrogen is the main culprit. And these symptoms includes the hot flushes, which is also called as flashes, sleep disturbances, mood disorders such as irritability, anxiety, and depression, sexual disorders, dyspareunia, that is painful sex, loss of libido, bony aches, fatigue, urinary symptoms such as urgency. Urgency means she cannot wait for the, I mean, a washroom. She had to visit at any cost. Incontinence means leakage of urine, right? Especially stress. Incontinence means if she coughs or sneezing, it will cause leakage of urine. Okay. Also, she will be liable to infection. Menopausal women, they suffer from infection. They get the infection very frequently, vaginal infection. Okay. Then dyspepsia and constipation. Androgenic manifestations, as we had discussed in the previous slide, that there is formation of androgens. So it will lead to increase in body hair. It will lead to thickening of voice also, because these are the function of androgen, mainly testosterone. Also, few hair on the chin. Increased body weight with skin and hair changes, right? So these are the symptoms. Um, we'll discuss a bit more about the hot flushes or flashes. It is more common at night, but can occur at any time. Okay. So what happens here in hot flushes? There is heat in the upper chest, neck, and face. The lady will feel heat over her face, chest, and neck, and it will be followed by increased sweating and heart rate. Increased heart rate. It lasts only for 1 to 5 minutes, right? And as I said, it is associated with uh, increased sweating and increased heart rate, followed by chills. Also, I mean, this hot flashes, it occurs in every woman, but it can be precipitated by stress, hot environment, and spicy food. It causes sleep disturbances, fatigue, and distress. So, this is about the hot flashes. For this, here they have explained. Uh, See, what they have shown here is thermoneutral zone, right? So, normally, what happens? Uh, our this one thermoregulatory set point, thermoregulatory set point, which is in the hypothalamus. Okay, it is set in a comfortable zone, right? Comfortable zone normally, but because of estrogen deficiency, what happens? It narrows the uh, this hypothalamic set point. How? See, this is the upper limit and this is the lower limit. So, because of deficiency of estrogen, it narrows this zone by decreasing the upper limit. Suppose this is the upper limit and this is the lower limit. So, it decreases the upper limit and increases the lower limit. So, now this window has become very narrow, right? The same is explained here. Concentrate, decrease estrogen. So what happens in the central nervous system? There will be motor vasomotor instability, and there will be increased norepinephrine secretion. Also, it will increase the serotonin secretion. Norepinephrine and serotonin secretion, it will increase, which will lead to narrowing of the thermoregulatory set point in the hypothalamus, as I have explained here, because of estrogen deficiency, right? So, because of this, the female, she gets these symptoms. There is hot flashes, night sweats, sleep disturbances, depression, daytime fatigue, right? So, this is the explanation for this symptom. Also, as we have discussed here in short, um, effect on the urinary system, that is here, urgency and urinary incontinence, right? Infection. So it can be explained here, because of decreased estrogen, the urogenital mucosa, it will decrease the synthesis of collagen. At the same time, it will decrease the blood flow in vaginal epithelium. So because of this decreased blood flow, what will happen? There will be decreased glycogen production, decreased energy source for lactobacillus which are present in our vagina, right? So because of these changes, ultimately there will be change in vaginal pH. It will increase. It will increase. Vaginal pH is increased, which is not normal for our vagina. And eventually, the female will suffer from dryness, vaginal dryness. There will be itching, irritation in vagina, and because of the change of pH, she will be liable to get more infections in vagina, dyspareunia, as I said, painful sex because of this change in pH and other changes which took place in the urogenital mucosa. Also, because of this decreased blood flow, the secretions will also reduce. There are vaginal secretions, okay, normally, which will be decreased. Also, there will be epithelial atrophy, vaginal epithelial atrophy, that will also contribute to these changes which are taking place in the vagina. Now, this part, decreased collagen synthesis, there will be weakening of vaginal walls. Okay. And that is the reason for stress incontinence. As I told you, that there will be leakage of urine, especially on coughing or sneezing, laughing. So there will be stress incontinence. Also, there will be pelvic organ prolapse, like cervical prolapse, cervix, it comes out in the vagina. Okay, that is due to the weakening of vaginal wall, which occurs due to the decreased collagen synthesis. Right. So these are the changes which are taking place um, in menopause in the urogenital mucosa, and that is all because of decreased estrogen synthesis. Okay. Now, effect of decreased estrogen on cardiovascular system, it will increase the total cholesterol. It will increase the total cholesterol. More precisely, it will increase the LDL, which is a bad cholesterol, and it will decrease the HDL, which is good cholesterol. Okay, so it is the adverse effect on the total cholesterol due to the deficiency of estrogen. On the other hand, it will cause uh, decrease prostacyclin, increase endothelin. It will decrease the nitric oxide synthetase, and it will increase the angiotensin converting enzyme. So, what is prostacyclin? it is uh, synthesized by the vascular endothelium and vascular muscle. Its action is antiplatelet. Okay. Also, it causes vasodilatation. Okay. So, it is good for our blood vessel health, but it is decreased due to the lack of estrogen, right? Then this endothelin, it is secreted from the vascular endothelium. What it causes? It causes the constriction of blood vessels, and it raises the uh, blood pressure, right? So it is increased. It should be less, but it is increased, right? Also on nitric oxide synthesis, this is the enzyme, right, which regulates the synthesis of nitric oxide. What is the function of nitric oxide? It regulates the tone vascular tone, or you can say indirectly that it helps in the regulation of blood pressure. So these effects are, altered due to the decreased estrogen. Our body don't want these changes, but it occurs due to the decreased estrogen. Okay. So finally, and this one, increase angiotensin converting enzyme. So this enzyme, it converts angiotensin 1 into angiotensin 2. And this angiotensin 2 is a strong vasoconstrictor. It will increase the blood pressure, right? So all these changes finally it will lead to vasoconstriction and endothelial dysfunction, right? And because of this, there will be increased risk of atherosclerosis. What is atherosclerosis? It is the change in the vessel wall, vessel wall, atherosclerosis. So what happens actually in atherosclerosis? The vessel, it will start developing plaque. So because of this plaque, what happens? The diameter is reduced, right? And ultimately, it will lead to increased blood pressure. Okay. So these combined effect due to increase of total cholesterol and these changes, there will be increased risk of atherosclerosis, and eventually there will be increased risk of myocardial infarction. So this is the effect of estrogen, lack of estrogen on the cardiovascular system, right? On bones, what happens? It decreases the osteoclast apoptosis. I hope you know the concept of, osteoclast activity and osteoblastic activity. Okay, this is for bone formation and this is for bone resorption. Okay, so due to lack of estrogen, uh, this osteoclast, right? It's apoptosis. Apoptosis is what? Programmed cell death, which normally occurs in our body, right? But it is reduced due to lack of estrogen, okay? And it occurs via decreased tumor growth factor B, okay? And on the other hand, what happens in the bones? There is decreased OPG. OPG is osteoprotegerin. Okay, osteoprotegerin, OPG. Later in the slide, they have mentioned the full form, so don't worry, OPG. So decrease OPG secretion by osteoblasts. Because of that, see, here I'm just uh, trying to make you understand by this flow chart. Later, they have given in detail. I will explain in the later slide. But as of now, just concentrate on this flow chart that there is decrease OPG. So because of that, there will be increase in rank ligand, which will lead to increase osteoclast maturation and survival. And when there is more osteoclast, okay, So it will lead to bone resorption, more bone resorption than bone formation. And when there is this imbalance, it will lead to osteoporosis. Normally, there should be a balance between bone resorption and bone formation. But because of the certain changes, there will be more bone resorption than the formation. And finally, there will be osteoporosis, that is weakening of the bone. Okay. Uh, Now, effects on, again, we are continuing the effect of estrogen due to its deficiency. In vagina, again, it is a repetition, I think. Already we have discussed in the earlier slides. There is vagina is thin because collagen synthesis is reduced. There is loss of rugi of vagina, alkaline pH, as we have already discussed in the previous slide. It will be liable to infection with itching because of the dry vagina, right? In the breast, there will be atrophy with loss of glandular tissue and fullness. Vulva, there will be loss of fat and it will be itchy, right? On cardiovascular system, just now we have discussed, there will be increased cholesterol levels. The female will suffer from hypertension. CNS, there will be irritability, sleep disorders, depression, anxiety, memory loss. On bone, there will be loss of bone matrix, bone X, liability to fracture, especially the trabecular bone, spongy bone. Skin and hair, there will be decreased vascularity and collagen content with delayed wound healing. Okay, so there will be more wrinkles and there will be hair loss because the vascularity is reduced, right? Consequences of menopause, they include Alzheimer's and dementia, cardiovascular disease, and osteoporosis. Here they have shown the mechanism of bone resorption, right? So I think you are aware of these things. What they have shown here, this is the macrophage, right? It is present in bone, so it is called osteoclast. What you have to know is a osteocyte, osteoblast. So this osteocyte, it um, it forms the OPG. This OPG is osteoprotegerine. Osteoprotegerine. Osteocyte, it forms the OPG, right? And uh, this one, osteoblast, it forms the rank L. Just concentrate on these two things, rank L and this OPG. Rank ligand, it is the rank ligand which is formed by the osteoblast. Okay, and this parathyroid hormone, it stimulates uh, the formation of rank ligand. Okay, now concentrate here. What happens? Uh, Normal. This is a normal physiology. Estrogen, it stimulates osteocytes to secrete OPG. That is the osteoprotegerine. Osteoprotegerine. Estrogen, it stimulates the synthesis of OPG, right? And what is the function of this OPG? It prevents rank ligand from activating the osteoclast, because more osteoclast, what will happen? More bone resorption, okay, and it will lead to osteoporosis. So this is the normal process, okay, that OPG is formed, which is its production is stimulated by the estrogen. So estrogen plays a major role here, right? And this OPG, finally, what it will do? it will prevent the rank ligand from activating the osteoclast. So less osteoclastic activity, less bone resorption, and there will be balance in bone formation and bone resorption. But uh, due to lack of estrogen, what will happen? There will be less OPG, right, which cannot prevent the rank ligand. Okay, so there will be more osteoclastic activity. There will be more osteoclastic activity, and finally, it will lead to bone resorption and osteoporosis. See this figure? This is the estrogen, right? It stimulates the production of this OPG by the osteocytes. And this rank ligand, which is produced, same here, which I have shown here, shown in the picture, right? This rank ligand, which is produced by the osteoblast. What we have discussed here, that this rank ligand, it is responsible for activation of osteoclast, but this OPG, it prevents. Okay, it prevents. So there will be no activation of osteoclast. So OPG is important, and this OPG synthesis is dependent on estrogen. So when there is deficiency of estrogen, finally there will be more and more uh, activation of osteoclast, which will lead to bone resorption and osteoporosis. Also, there will be calcium loss in the bone, which which support the osteoporosis. It occurs mainly in the trabecular bone, or you can say the spongy bone. See, this is the spongy bone. This one. This is the normal bone. Okay, and this is the bone with osteoporosis. Lot of uh, spaces here, right? This is due to the loss of calcium. It mainly involves the vertebral bodies, long bone shaft of the long bones, and heads. Also the pelvis, right? Osteoporosis increases the risk of hip fracture. See, postmenopausal women, they are more likely to get the fractures, even if they fall from the sofa, right? Or as in your case, she tripped on the uh, carpet and she broken her bone. Okay, because bone is fragile. The bone has developed osteoporosis. There is weakening of the bones. Normal person, adult or the children, they won't. If they fall from the sofa, they are less likely to get the fracture. But these females, because of the weakening of the bones, they get the fracture. Now, the treatment of menopause, estrogen replacement therapy. Estrogen replacement therapy. In this, first comes the bisphosphonates. This decreases the osteoclastic activity. Okay, so it will reduce the osteoporosis. Then the calcitonin, it also decreases the osteoclastic activity. Raloxifene, Raloxifene Evista, this is the trade name. It is a selective estrogen receptor modulator, okay, which has estrogen like effect on bone, and it decreases the LDL cholesterol. So, in this way, it will reduce the cardiovascular morbidity and mortality. Also, we can support by giving vitamin D and calcium, which is very important. Again, the repetition. Yeah, Women who develop menopause, okay, they put on weight, right? Mainly the abdominal. So these hormonal changes, which we have discussed in the previous slides, okay, they will lead to uh, accumulation of fat in the abdomen. This is the preferential place. It is preferred, okay, in the abdomen. In the abdomen, mainly the fat it gets deposited. Okay. In this way, it will increase the abdominal and intra-abdominal uh, obesity. Management of menopause. The first and most important is reassurance. Okay, and this symptoms are this measure is more important if the symptoms are mild and tolerable. Tell the lady that it is a natural process, everyone gets it, and it is transient, it will go. Okay, it is not permanent. Lifestyle adjustment include it includes exercise and dietic adjustment. Balanced diet means more protein, more fiber, and less carbohydrate. Hormonal replacement therapy, if the symptoms are very severe and distressing, because hormone replacement therapy has got many side effects, right? So it includes the estrogen therapy. Also, it is combined with progesterone, which is called as estrogen and progesterone therapy. Also, one can give, if the symptoms are very distressing, sedatives and antidepressant. Hormonal replacement therapy, it can be given orally, transdermal patch, topical as vaginal cream. Okay. So it has its pros and cons, benefits and risk. Benefits relieve symptoms and improve quality of life, but increase risk of breast cancer. Okay, increase incidence of blood clots, increase level of triglycerides, increase risk of uterine cancer. Benefits, as I said, it will improve the quality of life, as it will prevent vaginal and urinary atrophy. It will improve skin and hair. It will decrease cholesterol and it protects against osteoporosis, but having this risk. Okay. Side effects of HRT: colon cancer, endometrial cancer, dementia, macular degeneration, insomnia, ovarian cancer, diabetes, breast cancer, clotting, arthritis. Disorders of menopause. It can occur before the age of 40 years. Okay. It can occur before the age of 40 years or after the age of 55 years. Okay. Cause, it could be idiopathic, surgical, destruction by chemo or radiotherapy, destruction of ovaries, right? By chemotherapy or radiotherapy, if the lady is suffering from cancer or any other tumor, so and she is on treatment. Okay, premature ovarian failure. Premature ovarian failure. Here it could be idiopathic or because of obesity. Idiopathic means there is no cause. Okay, cause is unknown. So it is called as idiopathic or due to obesity or functioning ovarian tumor. Okay. Onset of symptoms, it is more sudden and it is more gradual. So with this, we have, completed the topic. If you have any query, you can ask. And Leon, what you have asked, I have explained. But if I'll get something more, inshallah ta'ala, I will share with you people. Okay. Any other query, anyone?
Doctor,
Yes.
Is there an explanation for why estradiol or E2 have decreased other than that the granulosome cells have been tired or what? Or is
No, no.
this
See,
uh,
this estrogen is reduced because of the decreased number of follicles, right? This estrogen is
okay?
secreted from where?
Okay,
Estrogen
thank
is
you.
okay. Anyone else? See, most of the symptoms are just because of decreased estrogen. Shall I end the meeting? So we are done with the lecture. Thank you everyone for listening patiently.
Thank you, doctor.
Welcome, dear.